Before we get started, I just want to throw out a quick disclaimer. The Brainwaves podcast and all of its derivatives are intended for medical education only, and not for routine clinical decision-making. The speakers on the podcast, and particularly in today's show, do not speak on behalf of their respective institutions, and their personal practices and beliefs do not reflect the practices and beliefs of where they work. Also, the cases discussed in this week's program were real cases, but as usual, we have intentionally left out any patient health identifiers in order to protect the patient's rights to privacy. And we've left out any identifiable information about physicians, nurses, pharmacists, and other medical staff so as not to falsely incriminate them for any medical or legal wrongdoing. The cases discussed over the next 40 minutes were not fact-checked and do not include all the relevant clinical details. Therefore, any information that comes up in the show does not constitute legal testimony. All right, let's get on with it, shall we? While rotating the neurocritical care unit, I heard a joke by one of the fellows, Dr. Iatrogenesis.
Into the microphone.
My name is Iatrogenesis. I'm a neurocritical care fellow at the Hospital University of Pennsylvania.
Okay.
Now, some might find this joke socially insensitive, even go as far as calling it racist, but I assure you that neither Azid nor myself intend for it to come off as demeaning. So if you're one of those people whose ears are easily offended by crass humor, in spite of our generally good intentions, please fast forward through the next 4 minutes or so. Okay, here's Azid.
3 ICU patients are magically teleported into the rainforest atop a circular wooden platform. Around the platform are blazing torches. In the trees beyond the torches, dozens of tribesmen are banging on their drums, chanting, "Chi-chi, chi-chi, chi-chi." The chieftain, a wizened old man with a long graying beard, wearing a necklace of teeth, hobbles forward to approach the 2 ICU patients. He turns to the first ICU patient, points, and asks him, "Death or Chi-chi?" The tribesmen go wild at the mention of Chi-chi and bang their drums furiously. The torches intensify at the mention of the word. The ICU patient, who has no idea what Chi-chi is but does not want death, timidly states, "I choose Chi-chi?" And so he gets intubated, sedated, Foley catheters inserted, subclavian central line is placed, hypoxemia ensues, a large pneumothorax is discovered, chest tube is placed, an intercostal artery is severed in the process. He goes into ARDS, becomes encephalopathic, gets restrained. He breaks free of his restraints, or perhaps his restraints were not retied after rounds, and falls out of bed, cracking his skull, while self-extubating and vomiting his tube feeds on the way down. He remains comatose, and the chieftain, who just so happens to be a neurointensivist, directs the placement of an intracranial monitoring device. The patient is re-intubated, has to be the 3rd time by now. He arrests. And despite an hour of high-quality CPR, the patient expires. The chieftain then turns to the second ICU patient, points, and asks her, "Death or Chi-chi?" Now that you think about it, the tribesmen look an awful lot like house staff. The second ICU patient weighs her options carefully. "There's no way that's going to happen to me," she thinks to herself. And so she responds, "I choose Chi-chi." A stroke alert is called. She's taken to the CT scan where contrast is given, and she anaphylaxes. She's intubated. Her endotracheal tube is placed into her esophagus. She's placed on high-dose corticosteroids, Benadryl, Precedex, epinephrine, Levophed. There's no stroke on the head CT scan. The chieftain neurointensivist recommends continuous EEG. She awakens from sedation, and her blood pressure skyrockets as she realizes what has become of her. It's the Chi-chi. Her fluctuating EEG pattern looks like it could be normal, or maybe it's non-convulsive status. She's burst suppressed, Keppra, midazolam, propofol. Her blood pressure tanks, renal failure, a new head CT shows strokes everywhere. Sedation is weaned, but not before she develops propofol infusion syndrome. She's discharged to an LTAC, but not before she aspirates from her ET tube. And then it's all over. The 3rd ICU patient saw what happened to the first and the second. Before the chieftain approaches him, the patient cries out, "I choose death!" Everything goes silent. The chanting subsides. The torches blow out. The chieftain pauses, shaking his head. A moment passes. And then the chief replies, "Fine, fine. Death. Death by Chi-Chi!" I love that, man.
That's so good. Oh, that's terrific. While that joke is kind of funny in some ways, in the way that you'd find The House of God to be funny, the fact of the matter is that this story about Chi-Chi is really unsettling.
Yeah, I mean, I would just say it like
I
you're
know it's a
saying
joke,
story.
it's a parody of medical care,
So,
but it's kind of true, isn't it? And that's the subject of our show this week. Welcome back to Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that comes with it. I'm your host, Jim Siegler, and today on the program, how less can really be more. Don't go anywhere.
Hi, Brainwaves listeners. My name is Ray Price. I'm the director of the Neurology Residency Program at the University of Pennsylvania, and I also direct the Penn Neurology Board Review course, now in its 16th year. For those of you preparing for the initial or recertification examinations, you know this can be a stressful time, but it doesn't have to be. Our high-yield course is more than 50 hours of recorded lectures for you to review for up to 6 months before the boards, and 2 days of live or online case-based learning. Past participants have found this an excellent way to prepare with well-organized high-yield material and engaging lectures. And for those of you who prefer problem-based learning, we have over 1,000 board-style questions available to people who take the course. For Brainwaves listeners, we offer a $150 discount on registration fees if you enter the promo code WAVES2019. Just check out the website link in this week's show notes or Google 16th Penn Neurology Board Review. Again, the promo code is WAVES2019. That's WAVES in all caps, 2019.
I want to start off today's program with the maxim, primum non nocere. First, do no harm.
Do you say nocere or nocere?
Oh, I'm not I do not speak Latin, so I'm not going to.
This is Dr. Igor Rybinnik.
I am an assistant professor of neurology at Rutgers Robert Wood Johnson Medical School,
where Dr. Rybinnik is not only the neurology clerkship director, but he also produces his own video-based podcasts on YouTube if you search for the Rutgers Robert Wood Johnson Medical School Neurology channel. And he's also more fluent in Latin than I am.
It's primum non nocere.
Yeah, I believe so. I don't know. My wife is a classicist, so I believe it's non nocere or something along those lines.
Well, that sounds a lot more.
Anyway, primum non nocere.
Our first debate of the evening.
This is what the majority of U.S. medical graduates swear by when they take up their role as physicians and surgeons. First, do no harm. I bring this up not because it's probably the most common dictum in all of medicine, but because it's a historical blunder. We attribute primum non nocere to the Hippocratic writings, Hippocrates, our father of medicine, but Hippocrates never actually wrote the phrase primum non nocere. Point of fact, Hippocrates did write something similar about 400 BCE in his book On Epidemics, and I'll quote him in this translation. The physician must be able to tell the antecedents, know the present, and foretell the future, must mediate these things, and have two special objects in view with regard to disease, namely, to do good or to do no harm. To do good or to do no harm. Depending on the translation, some believe it to read as to help or to do no harm, but I think you get the idea. In a separate instance, he writes again, practice two things in your dealings with disease, either help or do not harm the patient. Now, I'm not an ethicist, but empowering physicians with this first remark, to do good or to help, before to do no harm, this is a vital distinction to make.
And so I think that saying it that way, to do good or to do no harm, is a completely different kind of command than first to do no harm. I think it kind of shifts the paradigm from being a more passive approach, which I think avoids like litigation and malpractice as kind of we would see it these days, to a more active approach in how we manage our patients and how we proactively try to solve problems and maybe take a little more risks.
Yeah, that's an interesting point. We were talking about iatrogenesis, and we're talking about what's the definition of iatrogenesis. And first, as physicians, we are trying to do good as point number one, while avoiding doing harm. We shouldn't be focused on not doing harm to prevent us from doing good.
I thought that was a fantastic point. Don't let our focus on doing harm keep us from doing good. But whether you inadvertently do harm by trying to do good, or if you happen to do harm by doing less and trying not to do harm, it still qualifies as iatrogenesis. So let's talk about that. What is iatrogenesis?
How would you define iatrogenesis?
Yeah, the basic premise of iatrogenesis is disorders that result from treatment of other disorders. And in its evolution, I guess the most modern definition now is any adverse effect of medical care.
So doing harm while trying to do good.
And that would include physicians and nurses.
And probably any other medical provider for that matter.
And would include acts of omission when we fail to do something.
Or by allowing harm to come upon a patient because of your own clinical error.
That would be my definition of iatrogenesis. It's sort of all-encompassing.
If you break it down, the root of the English noun iatrogenesis comes from two ancient Greek words, iatros and egenom. Iatros refers to the process of healing or a healer, and egenom is the past tense conjugation of the verb gignomai, which means to come to be. Therefore, iatrogenesis appropriately indicates something that's come to be because of a healer. But then, how does one differentiate iatrogenic injury from a pharmacologic side effect, or medical error? Or even distinguish iatrogenesis from harm that comes to a patient because it's part of the patient's natural clinical course? What is iatrogenic and what isn't?
A lot of the iatrogenic errors that we call iatrogenic, they are failures of a system. I don't think it's the providers that are the problem or the nurses or the individual cogs in this whole system. I think it's the whole system fails. Physicians and nurses and providers, they're all human. Even the best physicians or the best caretakers, they will make mistakes. That's just a given. That's a part of the course. But the reason we develop these systems of care is that we have multiple layers of security, so that if one person makes a mistake, the system should be able to catch that mistake.
All the redundancies and timeouts and safety checks, while they may slow down care in some ways, they've been built out of a system of pervasive errors, human errors. You order the wrong dose of medication, and the pharmacist or the computer picks it up. You specify an incredibly difficult blood pressure parameter to maintain. The nurse says, "That's crazy, you must have made a mistake." You're preparing for a lumbar puncture, and you have to pause before the procedure starts to physically identify the patient, verbally acknowledge the procedure, the indications, the risks, the benefits, and prove that everyone's in agreement that this is the appropriate medical care. When harm befalls a patient, as Dr. Rybinnik is saying, it's less and less the fault of a single individual. It's the error of a system.
At the end of it all, it's really the system that needs to be scrutinized and improved rather than individual physicians. Yes, in special cases, absolutely. If there is an issue of impairment or issue of education or practice outside of accepted parameters.
For anybody who's listened to the Dr. Death podcast, you know exactly what he's talking about here.
The physicians, in a way, they do police themselves because of the conferences we have where we discuss complicated patients and patients that didn't do well for any reason. But the bigger focus here should be fixing the system or improving the system to make sure there are multiple layers of protection.
So what if you were to then say in a patient who has epilepsy and you order them trileptal, and as you're managing their epilepsy is well managed, they somehow become dehydrated over time, develop an acute kidney injury, they retain the trileptal and they get a little bit toxic and stumble and fall and maybe strike their head and they have like a traumatic head injury. At what point is that then an unforeseen medical complication, or at what point is that iatrogenesis for maybe not so quite adequate monitoring? I mean, it's hard to kind of say one or the other.
Yeah, that's a tough one. That's you stumped me there because it's a clear-cut case of where, well, you could say that maybe dehydration and ataxia is a side effect of trileptal, but then that leading to a fall, which then leads to intracranial hemorrhage, that's something that's certainly unexpected. So it would fall under the category of iatrogenic injury, but that's not something that could have been foreseen.
We're throwing all these words at you and all these examples, and it all kind of dances around the medical concept of fault. Iatrogenic injury is, by definition, a complication of medical care that is the fault of a medical provider. Again, I'm not an expert on this subject, but the way that I think about iatrogenic complications is in two ways: inadvertent iatrogenesis and negligent iatrogenesis, errors of omission and errors of commission, as Dr. Rybinnik mentioned. Both are technically unintentional, but one is more careless or more preventable than the other. Inadvertent iatrogenesis, I would believe, is when the provider is acting with the best of intentions, but something unfortunate occurs. A patient with a high-grade glioma develops PRES after their first dose of bevacizumab. As long as the risks and the benefits of treatment with this drug were discussed with the patient and they were acknowledged by the patient, then this is just an unfortunate side effect. Negligent iatrogenesis, on the other hand, is more passive. It's a failure to act.
I've had a patient with an external ventricular drain, a patient with a mild intraventricular hemorrhage, and that drain stayed in longer than it probably should have.
Or going back to my example of the patient who had the high-grade glioma getting high doses of corticosteroids, what if they weren't monitored closely enough for hyperglycemia and they go into HH&K?
Even with the best residents, because I firmly believe that after hour 12 or 16 on call, even some of the best residents start to make mistakes.
Sometimes we are just spread too thin, and we can't do all that's necessary to be safe for the patient. And that's a whole other issue.
We definitely see these things. I think that when it comes to residents, it's important to supervise and it's important to expand their horizons. When it comes to colleagues, things are much more difficult, but what really saves us is being able to have a discussion, sort of interdisciplinary discussion, having a case review of sorts, a forum where multiple physicians can look at this case from all different sides. And it carries a lot more weight when multiple physicians say, you know what, we are not doing the right thing here. How about we change our course?
There was an ethics paper by Klaas and colleagues published in the Mayo Clinic Proceedings from 2014. The authors wrote, if a dermatologist misses a melanoma on a skin exam and the patient later dies from melanoma, that would not qualify as iatrogenic. Now, I'll say that the first author of this paper was a lawyer, and lawyers are more concerned with physician negligence rather than iatrogenesis. A non-negligent infliction of injury to a patient by a physician would technically qualify as iatrogenic, doing something like resuscitating a septic patient with fluids, causing pulmonary edema and prolonged mechanical ventilation. But legally, I would hope, the provider should not be convicted of malpractice. And in most of these cases, the physician isn't, because they actively tried to do something that they thought was in the best interest of the patient. Dr. Rybinnik and I shared a couple of other cases from our experience about medical errors in iatrogenesis. Here's one that he recalls.
There was an interesting case with an unfortunate outcome where a patient actually suffered a minor car accident, and came in with back pain.
Minor back pain.
And without any neurological deficits.
No numbness, weakness, incontinence, or retention.
And it ended up being a case of epidural hematoma.
Overnight, the patient quickly decompensated and eventually became paraplegic in the legs.
There was a delay in diagnosis
because the imaging wasn't acquired soon enough, and therefore no intervention could be offered.
The resident on call at night did order the proper study, but did not actually physically push the patient right into the scanner. And what ended up happening is the patient did go to the MRI. He was very tired. It was middle of the night.
The patient, not the resident.
And he sort of refused the MRI and decided that he doesn't want the MRI, and was brought back up to the floor. And you can imagine what happened in the morning. The epidural hematoma continued to expand and he developed spinal shock.
Cases like this happen all the time, particularly around delay in diagnosis. According to one nationwide analysis of neurological litigation claims over 2 decades in the UK, it was published in 2014, the most common reason for payout, the most common cause of patient harm, was a delay in the care of patients. Delay in diagnosis accounted for 42% of all successful claims, while delay in image acquisition and delay in appropriate treatment made up another 16% of all successful lawsuits.
I want to pitch a case to you of a patient that I came across recently, and I want to know do you think that this was an iatrogenic complication or just part of the illness process? So this is an older gentleman who had atrial fibrillation. He was well controlled on Pradaxa, and he had lumbar disc disease. He underwent a laminectomy 7 days after having discontinued his Pradaxa at the request of the surgeon. Post-operatively, day 2, right before he was about to start Pradaxa, he develops new neglect, new left-sided weakness, has a moderate-sized right MCA territory infarct. It's not amenable to TPA given the recent procedure, and also it wasn't identified early enough to take him to thrombectomy. To complicate things, that infarct then hemorrhages a bit, and he has more deficits. What are your thoughts?
Yeah, thanks for presenting that case. That's a case near and dear to my heart as a stroke neurologist. We certainly see a lot of this. Is a very common story for us where a patient is well controlled on anticoagulant for AFib, and then suddenly the anticoagulant is held for a procedure that presumably is necessary, and they take the risk of another clot. And we see that quite often. In reality, if you look at the data, and the data says that majority of the time, probably over 95% of the time, when you hold anticoagulation, nothing happens. Now, as one of my mentors used to say, even though the risk of embolus is very low off anticoagulation, if it happens to you, that's 100% because you're the only one of you have. So this is definitely iatrogenic.
It's iatrogenic. We made a medical decision, and this resulted in patient harm.
There's an approved treatment for atrial fibrillation. It was held to do this procedure.
And even though it was iatrogenic, medical legally, to cover you, it's always important to discuss the risks and benefits of any treatment, or the withholding of any treatment, and to document that you did this.
It is somewhat expected, even though it's rare.
Rare, like on the order of less than 0.5% risk of stroke when anticoagulation for AFib is held for just a week.
So from our standpoint as stroke neurologists, whenever an anticoagulant is held, our blood pressure shoots up and we develop tachycardia for as long as the patient is off anticoagulation until that patient goes back on anticoagulation, because we sort of have seen a lot of these. But it's a selection bias for us. That's all we see, people off anticoagulation having strokes.
This case would probably qualify as inadvertent iatrogenesis, as long as the risks and the benefits of treatment were discussed with the patient. You've probably heard of the I'm sorry laws, which most states have passed, in which a medical provider can offer an apology for a poor outcome. I'm so sorry that your husband developed a severe infection after we gave him alemtuzumab. You can say these things without legally implicating yourself. Before these apology laws came out, by saying these things, you were admitting fault. The American Medical Association's Code of Medical Ethics states it is a fundamental ethical requirement that a physician should at all times deal honestly and openly with patients. Now, this would have been a problem before the apology laws, because the rates of medical malpractice have climbed dramatically in recent decades. In the wake of medical error, the code states, patients have a right to know what happened.
And it's not so much that we need to assign blame. That's very counterproductive and doesn't help neither the physicians nor their future patients.
It probably only puts more fear into the minds of physicians so that they practice more defensive medicine, causing us to order more unnecessary tests, exposing patients to additional risk, or keeping us from intervening during a high-risk situation because we're afraid of the legal ramifications. While our malpractice lawyers provide a formidable checks and balances system for medical providers, they don't necessarily help us.
What really helps is just evaluation of the case.
Unbiased and unprejudiced.
What went wrong?
What is fixable out of all this?
How do we make changes?
And how can we prevent this from happening again to others?
I'm sort of a firm believer that a lot of misunderstandings and even litigation happens because the patient did not understand the full ramifications of treatments, or the patient or the family. So the physician-patient relationship is definitely at the center of all of this, especially when you're deviating from accepted practice.
Do you think that we're seeing more cases of malpractice because we're under greater scrutiny, or are we seeing more malpractice because we have patients that are unsatisfied with their care and that we just live in an increasingly litigious society?
It's wonderful that you bring it up. As you probably know, there was probably a much more litigious society at the end of the 19th century when malpractice really took off. But you're absolutely right. We can estimate at least that maybe 1/3 of the patient could be getting substandard care, but really in reality, only 1/8 of those result in some kind of a claim. One of the major reasons for suits would be, or rather 2 major reasons for suits would be the severity of the disability that results from treatment and lack of this strong physician-patient relationship and informed consent, where the patient doesn't understand what's happening.
Here's a little historical tangent. The American Medical Association's first code of ethics was written in 1847. Very little was known about medicine at the time. We didn't even know about bacteria or have medical schools for another half century. But the AMA made a point to denounce quacks for peddling their talismans and snake oils. In addition, the Code of Ethics forbade doctors from testifying against other doctors. The same courtesy was not afforded to people called quacks, and how quacks were identified was also pretty unclear. In 1903, the AMA's Code of Ethics was revised, but it continued to promote this theme of doctors protecting doctors. As a side note, there are some interesting components of the 1847 Code of Ethics which physicians might find hilarious today, like a statement which read that a patient should never weary his physician with tedious detail of events or matters not appertaining to his disease. Additionally, a patient should never permit his own crude opinions to influence his physician's attention to them. Basically, patients were barred from boring their doctors, and they couldn't embellish their medical history. Facts were all that mattered, and patients had to respect the opinions and the recommendations of their physicians. These and other related statements were actually promptly removed in the 1903 revision. By 1957, at the time of the next revision to the AMA's Code of Ethics, the doctor's decree against speaking ill of other doctors began to crumble, and by 1980, it was all but revoked. The AMA's new Principles of Medical Ethics, published that year, stipulated that physicians are now encouraged to expose physicians deficient in character or competence. This time period was an inflection point in medical malpractice, but physicians, we are a loyal bunch. Recent survey data indicates that 1 in 6 physicians work with someone who they feel to be incompetent in caring for patients, but a third of us won't report it. In the years following the 1980 revision to the Code of Ethics, the number of malpractice lawsuits would climb regardless, and not necessarily because of physician incompetence. It may have a lot to do with how physicians interact with our patients.
Imagine we have these complicated computer systems, and we spend a lot of time reviewing charts, writing notes, doing billing, reviewing imaging, and we spend a lot less time at the bedside talking to people. So that's probably what's driving the big divide, because if a patient understands why their doctor recommended a procedure, prescribed a medication, and if they do get an iatrogenic side effect from that prescription, they are more likely to accept it if they understood why they went into it in the first place.
Risks and benefits must always be discussed, and informed consent, or at minimum assent, should be obtained, just like I do for every episode of Brainwaves.
Rybinnik, I just need your verbal consent for the use of this audio recording for the purposes of the Brainwaves podcast.
Because you can imagine that as we discuss these controversial legal issues and patient examples, I need to make sure that Dr. Rybinnik agrees to me publishing our interview.
Yes, this is Dr. Rybinnik, I agree.
You see, he agreed. And the reason he agreed to take on this interview, and the reason that anybody consents to medical care, is that there's a promise, or at least the hope, of some sort of benefit. And this leads us to the concept of double effect. In medical ethics, double effect refers to a situation in which something the provider does produces a visible, measurable positive change for the patient, while at the same time also causing some harm. This would be like up-titrating a patient's carbamazepine for seizure control, but inadvertently causing liver injury or causing a drug-induced lupus state.
Or you're tweaking the settings of a regional nerve stimulator, and then now they're getting more slurred speech.
Most medications, as you know, are toxins in some way.
I think this is where you really need that physician-patient relationship, where you need to ask the patient what's acceptable to them.
So you ask your patient, is it okay if we adjust your carbamazepine, or if we tweak your DBS settings? But historically, if you look back into it, double effect was an argument used by Thomas Aquinas, who was a 13th century Italian scholar and theologian, to justify self-defense in the event of life-threatening attack. Because at the time, the Christian church said that you can't defend yourself and kill somebody if they are attempting to kill you. Double effect has much less merit when we think about these less severe risks, like minor bleeding during a routine EMG, or the anxiety provoked by an MRI scan.
There are some cases that are more clear-cut. For instance, if a patient has a stroke and it's a disabling deficit, giving TPA is clearly more beneficial than withholding it. But there are some other cases where, well, what's acceptable? We are giving you a toxin. Let's say you have very mild deficit, hand weakness, a facial droop, but you're within the window of thrombolysis. Most of stroke physicians would probably recommend that you should be getting the approved therapy for stroke, but that therapy carries the risk of bleeding.
A 5 to 7% risk of major intracranial bleeding, and then also the risk of bleeding to other parts of the body.
We don't expect this drug to cause bleeding. We do expect this drug to help you more than harm you.
Which is what we tell the patient, so they understand why we want to give this drug, and to get their buy-in or assent to their own medical care.
But there's a very real possibility of harm.
Is that acceptable to you, you might ask?
What would you like, in a sense? Yeah. One question I wanted to ask you and kind of get your thoughts on the matter is, we were talking about informed consent and sort of bringing the patient along with us in our decision making. But obviously, in an emergency situation, it's very difficult to get the patient to quickly understand what's happening. When I was a fellow where you are, certainly enrolling patients in trials and hyperacute trials where we have to consent a patient in half an hour or an hour from stroke onset and randomize them into a trial, that was a huge challenge. Do you think that informed consent in this acute setting is a fallacy? Do you think that the patients understand what's happening to them, or are they busy being concerned about what's happening to their body to really listen and understand what's going on with them and being able to participate with you in the decision-making process?
Yeah, I think that's an excellent question. And frankly, I'm horrified that I'm put on the spot for this kind of thing, given my level of expertise. But I will say that my experience with the literature on this is that I would say many experts, not me, would say that a lot of the time a patient comes into the hospital, I think that their decision-making process is certainly impaired. And a lot of patients that we ask, even in the subacute setting, are not quite in their right state of mind to make decisions on their behalf, whether it's for routine medical care or for clinical trials. And, as a corollary, I would say that in patients who come in acutely with their illness, especially with stroke, when cognitive symptoms become the most disabling deficit, it's very different for somebody who has a broken foot or ankle to say, yes, I agree to a randomized trial of morphine versus no morphine. Like that you should be cognitively intact enough to make that decision. But somebody who has neglect of the left side of their body, they may not even care or be concerned that there's a treatment option available for them to help regain motor function. So I think that in those situations, especially whenever there's a time when the patient's ability to consent or even assent on their own behalf, when that's called into question, you've always got to go to their next of kin or their primary decision maker. And I always end up doing that. Earlier today, I ended up consenting a mother for her younger daughter who had come in with a stroke affecting the non-dominant parietal lobe. And I discussed the risks and benefits of the trial with the patient, obviously, but I ultimately obtained the informed consent of the mother after going through the risks and the benefits of the trial. So I think it's always better in general to obtain the buy-in of other family members and next of kin.
Yeah.
But it's a very hard line to draw.
This was an interesting question. And as I reflected more on this after our interview, I was curious to know how a patient's decision might change throughout his or her care, the intra-rater reliability of a patient's decision-making. If deciding, for example, you're the kind of person who does not want chest compressions or shocks or intubation before you're hospitalized for some critical illness, what are the chances that when you're actually faced with that decision to be put on a ventilator, would you change your mind? Do you understand the risks and the benefits more of any treatment before the fact, when you're of sound mind and of good physical health, or in the heat of the moment, when confronted with death or severe disability? So I looked into this. There was an interesting paper in the New England Journal from 2010 reviewing the care of nearly 4,000 patients. About 2/3 of patients had advanced directives, and in my experience, we don't even get this lucky. Of the surveyed families, 70% of patients who needed decision-making in order to determine their course of care, either fully aggressive intervention or comfort measures, 70% of patients lacked decision-making capacity when they were formally assessed. So if you think about it, how often do you ask a patient, would you like us to try to save your life if your heart stops beating? And then they say, yes, do everything. If 70% of these patients lack the insight to make the best decision on their own behalf because they are critically ill, or they're cognitively impaired, or they're suffering through a serious infection, or maybe they're delirious, how acceptable is this patient's decision to remain full code? Are they of sound mind, or could they be panicking? Dr. Rybinnik shared a story about this.
I treated one of our own emergency room physicians,
A patient obviously with strong medical literacy,
for stroke with TPA. And obviously that person is a physician.
someone who knows about TPA, has given it plenty of times before.
They've watched TPA being administered. They know the side effects. They deal with them.
So a fully informed patient.
And I explained to my best knowledge, even probably I went into more depth than I typically would,
To ensure the patient was fully informed.
explaining the TPA and the side effects and treating that person, even though that person just had mild deficits and was completely unimpaired mentally.
A competent patient.
After the treatment, 24 hours later, when the deficits improved, I asked that person, so do you remember me talking to you in the emergency room about TPA and side effects?
The ED physician, the patient, replied,
I was not paying attention to you at all.
had no recollection of the informed consent discussion.
I don't know what you said.
Not a single word.
My response was, just do what you need to do.
Now, whether this patient was fully informed at the time, was clinically competent, and able to make a medical decision for himself, and he just blacked it all out. Yeah, that could have happened. But what if the stress of the event was serious enough to have impaired his judgment at the time of Dr. Rybinnik's discussion?
Kind of underscores my perception. I'm certainly not an expert on this either, but it underscores my perception that it's much more difficult to get informed consent in an acute setting from the patient. And I absolutely agree with you that you sort of need a surrogate, almost a family member, to understand what's happening as well.
As we're wrapping up and considering what Dr. Rybinnik and I discussed, there are several important take-home points. First, iatrogenesis and risk-benefit relationship and side effect, these can all be synonymous concepts. The key difference is not the consequence or the final outcome, but the path that was taken to arrive there. Were all appropriate steps and safety precautions taken? Was the patient fully informed? How many other healthcare providers participated in the medical decision-making? And were there any disagreements? Second, most healthcare facilities have integrated systems of surveillance in their medical care. These are key to preventing unintentional harm in the era of electronic medical record, copy-pasting, and automated order entry.
With every unexpected outcome, we need to modify our system to make sure that surveillance is happening.
Ensuring these safety nets are effectively identifying errors and are vigilantly monitored can prevent patient harm.
To some degree, that requires improvement in our information technologies, our medical records, particularly helping physicians with drug-drug interactions and allergies and things like that.
And at the crux of it all is the patient-physician relationship.
Yeah, absolutely. Physician-patient relationship is at the center, like I said.
Because even if all your safety nets and redundancies fail to prevent a medical error or iatrogenic injury, having that strong tie with your patient, getting in that FaceTime, acknowledging and respecting their wishes, apologizing when necessary. We're talking about simple Southern manners. This can help you avoid most unpleasant patient encounters and legal battles.
But our greatest tool, besides the physician-patient relationship and fostering that, is us policing ourselves to some degree, us having conferences, us discussing challenging cases and cases where patients did not do well because of iatrogenesis or in spite of our best treatment. Having that discussion with your peers, that is one of our greatest tools. So that would be a great takeaway of physician-patient relationship, systems improvement, and having a self-policing environment sort of discussion of the cases with the peers.
I guess there could also be a third form of iatrogenesis, intentional iatrogenesis, whereby a healthcare professional knowingly and willingly commits harm to a patient. But we're not going to talk about that today because I think it's extremely rare, and obviously it's terribly wrong. The other two forms of iatrogenesis, on the other hand, inadvertent iatrogenesis and negligent iatrogenesis, which again are terms that I just came up with, they're probably not validated anywhere else. These two forms of iatrogenic injury are not as clearly cruel behaviors by a healthcare provider. So where are we going with all this? How does the future look for physicians and patients? Is iatrogenic injury something we have to worry about more and more? Or, with rising surveillance mechanisms, electronic order entry checks and alerts, double checking of important or high-risk meds, should we expect to see less iatrogenesis?
In general, there's this huge awareness of a topic of burnout.
This shouldn't surprise anybody.
And burnout among residents, burnout among attendings. There's a lot of publications coming out in neurology, our own sort of green journal, and there's a huge focus on that. And there's several reasons for burnout, certainly calls and long hours and being stretched and overtaxed. That's a reason for burnout. Dealing with systems of care that are complicated, especially electronic medical records that are complicated. So I think as the systems of care become more and more complicated, there are more and more things that are more and more boxes we need to tick, basically, to take care of a patient. As we get more removed from the patient, we run the risk of having more iatrogenic errors. Because if a resident doesn't have to worry about writing 10 notes,
instead, they spend more time at the bedside, talking with a patient, examining a patient.
And maybe as a result, he doesn't spend as much or she doesn't spend as much time making beautiful notes or long, extensive notes.
Then maybe that care that you're delivering, and not the documentation of your care, would go a longer way. None of this is particularly groundbreaking material. I know you've thought of it too. But it is curious to imagine the trajectory we're on when it comes to the future of medical errors. That wraps it up for another week on the show. Again, I'd like to thank Dr. Igor Rybinnik for joining me and sharing his experiences and insights. There's a lot that we can all learn from these stories and from each other as we continue to work together in the name of patient care. And there's still a lot much more we didn't get into today, a whole other side of the coin, in trying our hardest to prevent iatrogenesis or trying to, quote, do what's best for our patients. We may also be exposing them to a greater risk, the double effect principle, the chi-chi. I know it's kind of a joke, but think about all your inpatients right now, having daily labs drawn at 3 a.m. with painful needles, and this contributing absolutely nothing to their care. Think about the patient with an asymptomatic meningioma, who you referred for surgical resection, and the patient had an MI because of general anesthesia. This could have been entirely prevented if you hadn't tried to do what's best for the patient. The principle of beneficence, or doing good for the patient, it must be balanced with non-malfeasance, or not doing harm. And sometimes it's hard to tell the difference. That's it for us on the show this week. Don't forget, if you happen to be taking your boards this year, whether it's your first exam or you're recertifying, the Penn Neurology Board Review course is a fantastic way to navigate through the content. Take a look at the show notes in this week's program for the link to sign up, and if you use promo code WAVES2019, you can get $150 off your registration fee. That's WAVES in all caps 2019. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Our production team for this show includes myself, Jim Siegler, and Igor Rybinnik. Music was courtesy of Chris Zabriskie, Kevin McLeod, Mystery Mammal, Hyson, Fabian Measures, and Scott Holmes. Sound effects by Mike Koenig and Daniel Simeon. For more information, please follow us on Twitter or Facebook at Brainwaves Audio. And we'd love to hear from you if you have any thoughts about today's show or anything else we put out in the past. I'm Jim Siegler. Thanks for listening.